you work with Dr. Twardowski?
Yeah.
He was
I do.
my oncologist at City Hall.
Oh, really? Yeah, he's great.
Very nice guy.
Yeah, really like him. Waiting a few minutes to get everybody in here. We'll start. Microphone? It's coming down here. Thank you. You got a microphone for us?
Yeah. Steve had it.
Where's it at?
So Steve had the microphone, the one we want to use most.
Here it comes.
Oh, here it is. You want to try it out a couple times there?
We tried.
Working, okay. Is that, Steve, is that everybody, or is there still some stragglers?
I think they're all running for the hills.
Okay. This hill or another hill? Okay, that hill. All right. It's going to take me a few minutes to get through this. Well, I'm going to go ahead and start.
Can everybody hear me okay? Is this thing on?
It's really on.
Okay, thank you. Welcome to the Prostate Forum of Orange County. Before we get started, let me address some housekeeping items. The restrooms are located on the right side of the hallway outside of this room. We are pleased to announce that Steve Edmondson and I received a proclamation representing the forum from the Orange County Board of Supervisors, making the month of September 2018 Prostate Cancer Awareness Month in Orange County. In addition, we gave a presentation outlining the risks of prostate cancer and the importance of early diagnosis of prostate cancer. Also, we shared our mission and the work that we're doing with the forum and how people are involved and have been involved over the past 26 years. Steve, why don't you come up to the front of the room, please? This is the form. This is the plaque that we were presented. Does anybody have a camera that it could take a picture? I'd like to get it onto our website.
Gene, do you have, come on up. Why don't you take a picture of this?
Get him to move out of that slide.
Okay.
Let's see if we got enough light. If not, maybe we can take it on the podium.
Okay. Well, tell us what we need to do.
Okay. Let me see.
Anyway, while he's doing this, we did this in as your representative and as a recognition of the work that you guys are doing here with the forum. So this information will hopefully get around Orange County. Go ahead.
I've got all this light on the screen behind Steve, so if we could show this right up here. All right, go ahead.
Excuse me for turning my back on you. Steve and I have been going to the board meeting each year for the last 3 years and trying to generate interest in terms of what we're doing and helping people recognize that if they get a PSA when they're over 50 or if they have risk factors, they should begin that process when they're 40. And hopefully we're making some difference, making a difference. Also, Neil, the guy that took the picture here, him and his wife were at the Cruising for a Cure here on September 25th in the fairground. And what they do is they have about 35 vintage cars, and along with the vintage cars that you can see, they have a large room where they take your PSA and perform a digital rectal exam. And I'm taking these numbers off the top of my head, but in the past, I think maybe 1,200 people or so took advantage of that process, and about 30 or 40% of them were later told that they had prostate cancer. So early diagnosis is the key to being cured of prostate cancer. If you haven't signed up for a free membership, please see one of our board members, advisors at the meeting. They will sign you up. Becoming a member will automatically notify you of scheduled speaker presentations and other important events and information during the year. As you're probably aware, we are all volunteer organization. Our work at the forum is guided by our desire to help men with prostate cancer and their families, of course. Over the years, we've helped thousands of men, families, in many ways, including our advanced meeting, newly diagnosed meeting, our website with many online resources available, our repository for expert PCMDs on YouTube. We have something like, I would say 60 to 70 video recordings on YouTube covering all varieties and facets of prostate cancer. In the last 2.5 years, we've had 18,000 hits. And we're in the process of expanding that our presence on social media. In addition, of course, we have the live presentation of expert MDs, researchers, dietitians at our general membership meeting. We're in need of volunteers. Whatever your interest may be, we have a job role that will fit your interest skill sets. Give us an opportunity to work with you, whereby you can help more patients that are in need of our help. There's just so much that we can do at this present time. There's about 3 or 4 of us that are probably doing 50, 60% of the work. I mean, we just can't take on anymore. And there's so many people that men, families that we could engage in this process if we had additional resources. So really seriously consider helping us. There's so many things that you can do. I mean, we'll fit your interest with the roles and the jobs that we have available. Also, all of our services are free. However, we do pass the basket around to partially cover our expenses. Somebody pass the basket around. Dr. Krasne graduated from medical school at the University of California, Irvine in 1985. He then studied surgical and tumor pathology at Stanford University from 1985 to 1988, followed by a residency in laboratory medicine at the University of Southern California from 1988 to 1990. He joined the medical staff at St. John's Health Center in Santa Monica, California in 1990, and in 1994 became the medical director of the Department of Pathology and Clinical Laboratory, a position he has held for the past 24 years. At Stanford, in the mid-1980s, Dr. Krasne was a participatory witness in the early introduction of PSA, working alongside Dr. Thomas Stanley. Most of you people don't know who I'm talking about, Dr. Stanley, but for the people that have just joined us, okay, or just now getting started in their journey with this disease, he's one of the giants in the prostate cancer field. He gave the elevated testing with the PSA blood test to the extent that it has saved many, many, many lives. Previous to that, you know, it took a longer time to really figure out if you had prostate cancer, because prostate cancer doesn't have many symptoms in the beginning. With the PSA test, okay, you'll have an indication of cancer. You may have an indication of cancer before the symptoms arrive. When the symptoms arrive, it's much more difficult, okay, to manage cancer or to be cured. At Stanford, Dr. Thomas Stanley was at Stanford. Stanford urologist and co-inventor, as I mentioned, of the PSA blood test at the time. The transformation of prostate cancer management, which followed, sparked Dr. Krasne's career-long special interest in prostate cancer screening and diagnosis. Low-risk prostate cancer treatment approaches and active surveillance. And all of these bear on the importance and nuance of pathological grading and characterization of each patient's cancer. This topic today is Pathology of Prostate Cancer in 2018, importance of tumor grade and other nuance key to understanding a biopsy report. Today in no other human cancer are clinical management decisions so heavily based on cancer histological grade as determined by a pathologist. The main topic covered here today is review the spectrum of clinical behavior of prostate cancer, treatment benefits for low, intermediate, and high-risk prostate cancer, and how critically tumor grade guides decisions to treat, actively monitor, or observe a cancer. What a cancer grade and how to do pathologists assign prostate cancer grades. What are some of the problems areas prone to subject interpretive differences among pathologists and diagnostic errors? Please reserve your questions for after the presentation. Also, you're encouraged to ask questions, raise your hand, and we will bring the microphone to you. Let's give Dr. Krasne a warm welcome.
Thank you. If I'd known he was going to have to read that, I would have just written, please welcome Dr. Krasne, because he kind of just gave half my talk. But I don't know if this is a normal size crowd, but you know, it's not surprising to me that this topic maybe didn't spark too much interest, but it is really so pivotal to what you're dealing with. We describe the nature of your cancer, and it's not done the same by every pathologist. So in a way, you have to learn to be, I think it's ideal if you can learn to be your own advocate to some extent in this. And so I'm going to actually try to give you some tools to do that. To But to talk about tumor grade, you have to understand, for you to be interested in it, you have to know why it matters, right? Because we can do things, we can name tumors all day long, but if it doesn't make a difference, who cares? We can grade tumors, we grade all tumors, and it often doesn't matter. But in prostate cancer, it matters more than probably in any other cancer today, because the management decisions are so radically different. I will tell you that if I was here giving my, from Larry's comments, I think if I was giving my PSA screening talk here, you'd probably kick me out of here. For many years, I was against PSA screening. You know, I don't disagree that it saved lives, but I've been impressed by how many lives it unnecessarily harms as well. And I'm not alone in that. But I've come around. I've come around. I have a very balanced view, I think, of all this. But let's get started. I want to just show you a biopsy report that I saw yesterday. So someone had a prostate biopsy, and they came for treatment at our center. And so I was looking at this case as a second opinion, okay? And I wonder if anybody here can look at this report. So I've redacted, you know, the report, but I've left enough in here. Can you tell why this report may indicate there could be a problem with the report? Yes?
It looks like there's just a lot of benign prostate tissue.
That's okay, that's good.
A through C is missing.
Pardon?
Where's A through C?
Oh, no, that's not it. But good point. Oh, probably on the previous page. So I'll just tell you, I'm hoping at the end of my talk, you will be able to look at this report and say, okay, there's a problem with this, I may need a second opinion. And that was my first thought. Before I even looked at the slides, I knew there could be a problem here. And the two problems with this report are, and I know I can get myself in trouble, but I'm at a point in my career where I guess I can afford to get in trouble. First of all, look at the laboratory, urology specialists of something, California. So that means that this is a pathology report from a urologist's pathology lab. What that means is that there was a pathologist is hired by the urologist to work in a laboratory that the urologists own. And all this pathologist does all day is look at prostate biopsies. And I can tell you, when I got out of my training, the last thing I would have ever wanted to do would be stuck in some urologist's laboratory on salary just reading prostate biopsies all day. Okay, so it's kind of a desperate job for a pathologist to have to take. So number one, you're selecting for a pathologist who couldn't get a better job. I hate to be so blunt about it.
Excuse me. You asked a question. Let me answer your question. Okay, on D, you have positive for endocarcinoma, but E through L, you have benign prostate tissue, not showing where the cancer is.
Okay, so I'm going to tell you the two things are wrong. One is you want to be alert because you have a laboratory that's it's not the kind of laboratory you really want your biopsy seen at. Secondly, look at the Gleason score, 3 + 4 = 7. There's no percent pattern 4. So what I'm going to take you through, at the end of this, you're going to realize that 3 + 4 = 7 doesn't mean that much by itself. 3 + 4 = 7 could be a completely benign cancer, a pure Gleason 6. It might be a 3 + 4 = 7, or it might be more of a 4 + 3, depending on how much 4 there is. Okay, so if a pathologist is reporting 3 + 4 = 7 without telling you how much 4 there is, they're not giving you the whole story, and they're not practicing in a contemporary manner. And so this pathologist is behind. All right, and sure enough, when I looked at this case, there was no pattern 4 there. This was a pure Gleason 6. So my diagnosis was 3 + 3 = 6. So you had one core out of the whole set that was 3 + 3 = 6. And if this was this man's first cancer diagnosis, this is an ideal candidate to do nothing, active surveillance or less. So, but if you just take this at face value, 3 + 4 = 7, by many people's criteria, you don't qualify for active surveillance, you need immediate treatment. That's controversial. but it's very important that your path report really gives you the information you need and that it's accurate. Okay, so I was in my residency at this point in this curve of prostate cancer incidence increase, and that big rise in prostate cancer incidence is from PSA. The PSA test was approved for screening, probably in here somewhere. It was approved for monitoring cancer much earlier, but Dr. Stamey at Stanford was using it for screening before it was approved. And so we had our mini, when I was at Stanford, we had a mini peak like that, and it happened while I was there. So we went from no PSA to PSA screening, and all of a sudden we were diagnosing 5 times as many prostate cancers from one day to the next. And in my mind, because, now, another thing I want to tell you, oh, by the way, please no one tell me anything about the Rams-Vikings score if you hear anything, I'm recording it. Also, don't read my slides tonight, okay? There's a lot of information you don't need to read, so don't feel that you're missing something if you don't read through the slide. I'll tell you everything that I wanted to convey. You don't have to worry about reading my slides except where I point you, okay? So what this is showing is that the normal incidence of prostate cancer, as I'm a pathologist, I used to do autopsies, well I still do, but I did a lot of them when I was in training. And when you examine the prostate gland of a man that didn't have prostate cancer, we find prostate cancer a lot of the time. And these studies basically showed, one of them shows that the incidence of finding a prostate cancer is almost the age of the patient. So an 80-year-old man, we have an 80% chance of finding a prostate cancer who didn't have it clinically. Another study shows that it's 10, the age minus 10, so a 70-year-old man would have a 60% chance of having a cancer somewhere in there. A study at Stanford that I think is probably a little more right on showed that about 1/3 of men in their 60s had a prostate cancer, and these are men that had normal PSAs. So we know that there are a lot of benign prostate, clinically, biologically benign prostate cancers just hiding out in there that are never going to cause a problem. And that's the problem with PSA screening. The problem is that you're at risk of, you have an elevated PSA for any reason, you biopsy the gland, and you run into one of these meaningless cancers and you don't know it, and so then you get on the road to treatment, and your life has changed forever, and you would have been better off, it's actually something we call a Howard Johnson syndrome. You would have been better off staying at Howard Johnson's hotel than seeing a doctor that day. And actually, years later, I don't remember Dr. Stamey this old. He was much younger when I was working with him, but this is what he said years later. He said, what is urgently needed is a serum marker for prostate cancer that is truly proportional to the volume and grade of this ubiquitous cancer, a cancer we all get, I think he's referring to men, that we all get if we live long enough so that any excuse to biopsy the prostate has an excellent age-dependent chance of being positive. So he kind of changed his tune on the PSA test. And I want to show you some interesting data. This is on the top here, this number. There was the main screening trial from Europe that proved there is a survival benefit for PSA screening, and there's no question that there is. Okay, it saves lives. In that study, for men with PSAs greater than 3, they all had biopsies, and the chance of finding a positive was 24%. There was another famous study published in the New England Journal of Medicine. It's the prostate cancer prevention trial. It was the finasteride trial. And the men who didn't get finasteride, the 4,692 men, they all had a biopsy, whether their PSA was elevated or not, by the end of the study. And so, of those 4,692 men, 24% had a prostate cancer on their biopsy, regardless of their PSA. So it's just taking every man, biopsy every man, and the incidence is the same in that normal population as the men who had elevated PSA. This is some data. I want to run through this quickly because I want to get to the mechanics of grading, but I want you to see the importance of knowing the difference between low-risk prostate cancer and real prostate cancer. By the way, I don't mean to diminish the importance of real prostate cancer, okay? It kills 25,000 to 30,000 men a year. It's a big deal, but there are it's diagnosed about 250,000 men a year, and many of those men should be bothered with the diagnosis. This is some SEER data showing that for low-grade prostate cancer, in 180,000 men studied, their relative survival was over 100%. And what that meant was that the men with low-grade prostate cancer outlived men with no prostate cancer. And the reason was that these were men that sought medical care. So they had a diagnosis of prostate cancer. And so compared to the general population, they actually outsurvived them. Meaning that the cancer didn't have any effect on their life, that's all. This was a pivot trial. This is also a famous trial published in the New England Journal in the last decade that showed no treatment benefit to, it actually compared surgery versus observation, not active surveillance, just nothing. Observation versus surgery for prostate cancer, and it did not show a survival benefit from surgery. There were many problems with the pivot trial we won't get into, so, but leave it at that. And the point here is that there was a lot of data to support the U.S. Preventative Services Task Force recommendation against PSA screening. And what they were basically, I'm sure most of you know that the U.S. Preventative Services Task Force recommends against it. And their logic is, and this is where, well, I'll get into that, is that so many men are harmed with small harms and larger harms, with cancers that were never going to hurt the man, that if you add up all those harms, they felt that those outweighed the survival benefits of treating men who had real prostate cancer. And this has been debated forever, and I have to say that, even if you disagree with this, and I actually had sort of changed my tune. I had my first PSA at 58 last year, so I finally decided that I could live with getting a PSA test. And the reason I finally did was because of this derecommendation against PSA screening. And what it did was it made the urology community, they were so upset by it, but they had to change their ways. And so finally, mainstream urologists are actually showing restraint in managing men with low-risk cancer. And so now many doctors are being responsible with the information of a low-risk cancer and not recommending treatment. And because the mainstream practice has changed, I felt more comfortable go ahead and getting my PSA test. But you can see that I was biased against all this. I was asked to speak at the Prostate Cancer Research Institute patient conference in 2014 on active surveillance by Dr. Scholes, and you can see my bias even against active surveillance was that in itself is torture, right? Because you've got to live with the diagnosis of cancer, you have to get your PSA test done every, 6 months, or I don't know how often you get it. You have to get biopsies every year or every 3 years or whatever, depending on what your doctor likes to do. And that's a lot to go through. And every time you get a set of biopsies, your chance of infection goes up. So to me, active surveillance is no easy deal. And my last slide of that talk was this. Just at the time that MRI was becoming sort of in vogue and was technically so much better than it had ever been, we'd never had any imaging for prostate cancer. This was my final slide, and I was sort of thinking we needed to move towards just doing MRI and not biopsies for men on active surveillance. But anyway, more recently, the SPCG4 trial was published, or was updated at 18 years follow-up. And this is probably the best data now that shows the dramatic benefit patients get from being treated when they have intermediate risk prostate cancer, okay? So right here, the intermediate risk group, 15% prostate cancer mortality, 15% versus almost 40% with observation. So treatment works for this cancer, right? And this is actually, that may seem obvious to you, but it was never proven before. So now we know that if you have intermediate risk prostate cancer, treatment saves lives, for sure. This is also the first time ever that for low risk prostate cancer, even though there was no survival benefit, this is not significant, 10 to 14%, the difference in metastasis at 18 years was different. Okay, so metastases were reduced in patients who had surgery. And so we know that men, even with low-risk cancer, if they have a long enough lifespan ahead, they will benefit from treatment as well. So even with low-risk cancer that we're doing active surveillance for, if you have more than 20 years life expectancy, you stand to benefit from treatment. So let's just talk about active surveillance a little bit, only because we want to understand the importance of grade before we talk about grade. These are a bunch of different studies, series on active surveillance, and I've picked two that are the main active surveillance trials to sort of focus on, because one is at Johns Hopkins, is the super conservative trial, where you have to have just the lowest risk. In fact, they call it very low risk prostate cancer to qualify for active surveillance, versus the Toronto series. This is Dr. Klotz's. The Toronto series, they're more liberal, and they'll let you get in active surveillance with more of a cancer. So, to get in the very conservative one, you have to have a Gleason 6. This is the grade. You have to have a Gleason 6. You can only have 2 positive cores. You couldn't have more than 50% of a core positive, and you had to have non-palpable disease. So if they could feel anything, you can't get on active surveillance at Johns Hopkins. Whereas in Toronto, 13% of men had Gleason 7, they got on. Your PSA, about 10% of men had a PSA over 10 to 15, and you could have very significant palpable cancer and still get on active surveillance in Toronto. Okay, so what's the difference in how those men were doing? Okay, so in the Toronto one, where you can have you have more extensive disease and get on active surveillance, look at their survival, their cancer-specific survival at about almost 20 years is 94%. So 19 out of 20 men are fine are still alive, or not dead from prostate cancer. 19 out of 20 men. Whereas at Hopkins, 999 out of 1,000. Okay? So you have to decide as a patient, are you willing to live with this chance of prostate cancer getting you or not? And 19 out of 20 isn't too bad. But the bottom line is, if you look at these numbers of death of disease or metastasis for the Hopkins trial or the Toronto trial, your chances of a bad outcome are 5 times greater if you go for active surveillance and you have this more extensive disease. So in deciding if you're willing to go into active surveillance, you kind of want to talk to a doctor who understands the differences between these trials, so you understand what your risks are. And then the importance of Gleason 6, very important. There was a series from Johns Hopkins of 14,000 prostatectomies with Gleason 6, and none of those men, and none had metastasis. And they actually decided at that point that if you have pure Gleason 6, you have no chance of the cancer spreading. And there was another series that showed something similar. And an NIH consensus conference came out in 2011, and it suggested that strong consideration should be given to modifying the anxiety-provoking term cancer for this condition. They were talking about Gleason 6 prostate cancer. That's how people are looking at Gleason 3 + 3 = 6 cancer now. So what's tumor grade? Well, I'm going to skip this slide. No, I'll show it. So this is what colon cancer looks like. This is a low-grade colon cancer. This is a high-grade colon cancer. And this is normal lining of colon, and this is just a higher magnification of the normal lining of colon. And what I'm hoping you'll see is there's a resemblance between this and this. The point is the low-grade cancer looks much like the normal, okay? And the high-grade cancer, the cells go crazy and they lose their ability to what we call differentiate. And so they no longer look like the low-grade cancer. And high-grade cancers do worse, okay? That's the easiest way to say it. This is a section that I cut through a prostate gland. This was a radical prostatectomy. This is the back of the gland here. And I'm showing you, this is that black ink, so this is the back of the gland. Now we're looking at it under the microscope, and you can't really see the cancer here very well. This stuff here is the cancer. These things here, these little ones, these big things are not cancer. Here, let me make this easier. Okay, so this is a low-grade cancer right here. Here, this is the normal gland. Okay, so just like I showed you in colon, these cancer glands are little tubules, and they look like the normal gland. But when you get less differentiated, higher grade, this is Gleason pattern 4 with these fused structures. Okay, here's some Gleason 3. This is 4. We call that cribriform. This is getting more solid growth. So this is losing that Gleason 3 pattern. So here's some Gleason 3. This is Gleason 4. And then when they lose everything, Gleason 5. Pattern 5. Okay? And then when you get higher grade, they invade outside the gland into the fat. This is fat. This is what fat looks like under a microscope. And this is the cancer just invading outside the gland. So how do we assign tumor grade? So this is the original Gleason diagram. And this is how pathologists work. I mean, I'm just like you, except I went to school and I studied these diagrams and, you know, how we do this. And so, you know, you actually can grade cancer. I'm going to let you guys grade some cancers in a second here. So this is the original Gleason diagram, and it's been changed several times over the years because as we understand the outcome of these various patterns, we've shuffled them from one group to another. And the main change that happened between 2005 and 2010 was these, what we call cribriform shapes. They got pushed into here. See, so now in the Gleason 3 category, you don't see any of this because these do worse. And so we pushed these into Gleason 4, and now we've purified the Gleason 3 group, and that's why Gleason 6 is so benign behaving now. This is going to get a little complicated, but we don't use Gleason patterns 1 and 2. All right, so you don't ever use 1 and 2. So you only use 3, 4, or 5. And the problem with the Gleason score is that there are so many confusing, you know, arithmetic scores, right? Because you add the most common pattern and the second most common pattern. So if you have mostly 3 and a little bit of 4, it would be 3 plus 4 equals 7. If you have mostly 4 and a little bit of 3, you call it 4 plus 3 equals 7. And it just was confusing, and there were too many grade possibilities. So we've gone to these grade groups, 1 through 5. And the beauty of the grade groups, 1 through 5, is that they separate outcome very well. So Gleason grade groups are really just a simplification of something that was sort of unnecessarily complicated. But it's still good to know how the Gleason score works, and we'll talk about why. Another thing to know is that just because your biopsy is 1 grade doesn't mean that that's what you have, right? Because the biopsy is just a sample. So you could have Gleason 3 on the biopsy, but there's 4 in the gland, and they didn't sample it. And that's why these were biopsy scores, okay, biopsy grade. Gleason 6, 69, in this series of, whatever, 15,000 cases, 69% of biopsy scores were Gleason 6. But look, when they had radical prostatectomy, 38% of those men had something higher than Gleason 6. That's a lot. 40, that's 4 out of 10 chance that you have something higher than Gleason 6. So you can't trust the Gleason 6 on biopsy, this is suggesting, right? And on Gleason 7, the same thing. In this series, 25% of biopsies were Gleason 7. But look, 13% of those were upgraded in radical prostatectomy, and 17% were downgraded. So even though you thought you had Gleason 7 on the biopsy, when they took out the whole gland, it was all 6. So you wonder, how could that be? If I had 7, why is it in the gland? Well, we're going to talk about that a little bit. So although the biopsy score is not as reliable, of course, as the real score when you examine the whole gland removed, the biopsy score still is pretty predictive. These are men who had surgery and were followed. This is the biopsy score compared to the radical prostatectomy score. You see the separation of the lines is a little better here than here, but the biopsy score still is pretty predictive. So even though it has that unreliability factor, the biopsy score is still very important. All right, so now we're going to do a little exercise, a little game, okay? So does anyone want to say what patterns is Gleason what?
4.
No, this is a Gleason 3 because these are all well-formed tubules, and that matches this right here, okay? So we'll get you another one of those. We'll give you another chance. Okay, this one is not 3, right? Because these are not single tubules. So this fits with this stuff, okay? So that's a 4. So that would be 4 plus 4 equals 8, if that was what we saw on the biopsy. Okay, how about this? Anybody?
5.
Well, yeah, you would think it's 5, and actually it does look like this, so I can't fault you for that. But we wouldn't call this 5, we would still include it in the 4, so this is another 4 plus 4. But actually, if you're actually right in interpreting it that way, because you see that there. How about this one? These are all single cells, these are all tumor cells.
No definition.
There's no definition at all, that's right. And so that matches this. So this is a Gleason pattern 5. This is a classic Gleason pattern 5. All right, how about this? Anybody? It's a 3. This is pattern 3. So these are all single glands with holes in them, little tubes, and that's what those are. So here's another 3 plus 3 equals 6. How about this one? This is a tougher one. This has 2 patterns. So this has some of the simple tubes, but mostly not. Mostly these solid fused things. So this is a 4 plus 3, because it's mostly this stuff and a little bit of this stuff. So this is 4 plus 3. How about this one? Anyone want to try? Three plus 3. This is another Gleason 6. This one, okay. So here's a little trickier. So these are the tubes, and this is why pathologists start disagreeing with each other. You get different diagnoses from different pathologists. This is all, every pathologist will call this Gleason pattern 3, but this stuff here, they look fused. But the question is, if you think about a pipe, if you cut the pipe this way, and you look at it on end, you see the tube. But what if you cut the pipe on a diagonal? You could catch a big portion of the pipe wall, and we call that tangential sectioning. So a tangent section of a Gleason 3 gland could look like a Gleason 4 gland. And so some pathologists are going to call this Gleason 3 because it's just part of this, and they think it's just tangentially sectioned. And some pathologists will call this Gleason 4. Same thing here. This is all Gleason 3 up here, but down here these look more fused. And so some people are going to call that 4, and some pathologists are going to call 3. That's going to make a big difference in someone's life. You get the biopsy result of Gleason 6, 3 plus 3, or you might get a biopsy result of 3 plus 4. So this has been studied, and I'm showing you here results from this study where these investigators took 17 cases that had this issue that I just showed you, and they sent them to 11 urologic pathology experts around the country, and they went for their diagnosis. And the range of diagnosis was, between 7 and 15 cases got a diagnosis of sub 4, 41% to 88%. So depending on who your pathologist was, one pathologist diagnosed only 7 cases that were pure Gleason 6. Another pathologist gave 15 of them pure Gleason 6. And then, when they sent test set 3 a month later, It was the same cases, it was the same 17 cases. They sent them to the same 11 pathologists. And even the same pathologist only agreed with himself between 65 and 100% of the time. So even one pathologist changed his mind when he saw the same case twice. And so how do we deal with this? How do you deal with this, knowing that this is going on? So it's actually not so hopeless. So distinguishing tangentially cut Gleason, this is the first key grading point. Gleason 3 glands from infiltrative Gleason 4 is problematic for pathologists and a source of discrepancies. And so how do we deal with a case like this? Well, we call it Gleason 3 plus 4 equals 7, and we give the percent pattern 4, and we say 5% or less pattern 4. And I'll show you why that's important. And this is something that you need to know in reading your path report, right? Here was a study of 100, I think it was about 150 or so prostate glands, radical prostatectomies. And they showed that if you were Gleason 6 on biopsy, your chance of remaining Gleason 6 is only about 66%. 26% of the time, if you're pure Gleason 6 on biopsy, 26% of the time you're upgraded to 7 on radical prostatectomy. If you have less than 5%, if you're Gleason 7, but less than 5% pattern 4, your chance of of being pure Gleason 6 on radical is 64%. That's the same. So if you have a tiny amount of Gleason pattern 4 on biopsy, it may be equivalent to just a pure Gleason 6. Because if you had more than 5% pattern 4, Gleason 3 plus 4, but between 6 and 50% pattern 4, your chance of being pure Gleason 6 on radical prostatectomy is only 10%. Completely different than 66 and 64%. And so the point here is that when the pathologist says there's 5% or less pattern 4 in a Gleason 3 plus 4 equals 7, you have to know that you may really have just Gleason 6. And so even urologists don't all understand this, and so you kind of have to fend for yourself. So this is something that I hope you guys will remember. So the next key grading point here is Gleason 3 plus 4 with less than 5% pattern 4 may be similar to 3 plus 3 and may mitigate this issue of the tangential sectioning and pathologists disagreeing. And that's why it's so important to have a percent pattern 4 when you have a Gleason 3 plus 4. Is this pathologist disagreement just one little, results of one little study? No, this happens all the time. And I don't want you to read any of the slides except what I'm about to show you. This is the latest update on the PIVOT trial. And it's just almost sad, but it's funny to me, but it's sad also. If you look at the outcome for radical prostatectomy versus observation, in the intermediate risk group, it showed a treatment benefit, a small treatment benefit. But that was when the pathologist locally at the hospital where the surgery was done graded it. If they sent these cases to the expert at the central location and they graded them, there was actually a slight non-significant benefit to observing over surgery. And so you go from a 7.3% benefit to a negative 0.4% benefit, depending on who the pathologist was that graded it. That's how, so these results are screwy, and you can't even use this study really, in my opinion. But I thought that this was really quite a striking example of how big a difference it makes who your pathologist is. And it's hard to believe. I mean, we know that intermediate risk prostate cancer benefits from treatment. And so to show that there's actually a benefit from not treating intermediate risk when the expert graded it, there's something very wrong with this study. But it also shows you how much variation there is between pathologists. Okay, so is this 3 plus 4 or 4 plus 3? And that matters, right? Because 4 plus 3, no active surveillance option. Okay, that's a much more aggressive cancer than 3 plus 4. Well, it's about 50-50. And so how do you deal with that? Here's another one. Is it 3 plus 4 or 4 plus 3? I think this one's 4 plus 3, but this is something that pathologists struggle with. And this is a quote from an article that came from Hopkins, the Hopkins group. Borderline cases exist between Gleason scores 3 plus 4 and 4 plus 3 that we currently have to flip a coin to decide. If we record percent pattern 4, these ambiguous cases will be evident regardless of whether we diagnose 3 plus 4 with approaching 50% pattern 4 or 4 plus 3 with 60% pattern 4. This could also help explain potential differences in grading the same case between pathologists. So it's very important that you have a percent pattern 4, right? Because if you have 3 plus 4 with 40 to 50% pattern 4, you're really dealing with something that may be 4 plus 3. So you're talking about a more aggressive 3 plus 4. So if it were me, and I had a 3 plus 4 with 40% pattern 4, I would be worried about doing nothing. Whereas if I had a 3 plus 4 with only 5% pattern 4, I don't think I would do anything. So here's the way I handle a case like this. And this looks kind of pathetic, maybe. The pathologist says at least grade group 2. 3 plus 4 equals 7, 45 to 50% pattern 4, with a comment, pattern 4 areas comprise approximately half of the tumor, thus this tumor approaches grade group 3. Well, what I'm doing in my report here is I'm really turning a black and white thing into something gray and giving you more information, right? If I called this 3 plus 4, I'm potentially really misleading you. If I call it 4 plus 3, I'm misleading you. So I'm going to tell you exactly what you've got, and then you and the urologist decide what does it mean. And I think that a report like this that appears to be weak, at least something, is actually a more honest and useful piece of information than a black or white answer in a gray world. So the importance of reporting percent pattern 4, Gleason 7. A Gleason 7 can be more like Gleason 3 plus 3, 3 plus 4, 4 plus 3, or 4 plus 4. If you had a Gleason 7 that was 4 plus 3, 80 to 90% pattern 4, that really may be more like a 4 plus 4. That's a grade group 4. It's a very high grade cancer, right? And another problem with the grading system now is that Gleason 7 defines intermediate risk cancer in the NCCN guidelines. Yet Gleason 7 by itself now is a meaningless term because it could be so many different things, all the way from grade group 1 to grade group 4. Okay, here's another problem. When you have a very small focus of cancer, a very small area of cancer, this is the cancer right here. This is the benign, this is the normal gland, and this is the biopsy. So does anyone want to throw out, what's the Gleason pattern there? Is it 3? No. Maybe it's 4. But what we do when we look at prostate biopsies is remember, you have a piece of tissue that has thickness, right? But in the glass slide, you only see one slice through it. And so we cut through different levels to get looks at the cancer at its various levels, right? And so this same cancer focus I just showed you in another level looks like Gleason 3. So it looked like Gleason 4 in one level and Gleason 3 in another level. And so what is it? Is it 3 plus 3 with tangentially sectioned glands up here? Or is it 3 plus 4 or 4 plus 3? Well, think about how in the extreme, if you only had 3 cancer glands, and one of them was a Gleason 3, and one of them was a Gleason 4, and you were struggling to decide if the third one was a 3 or a 4, think of how silly that is, because based on one gland, your subjective interpretation of one gland, this man's either going to get a grade group 2 or a grade group 3. Gleason 3 plus 4, if I call this 4, no, excuse me, if I call this a 4, it's going to be a 4 plus 3. If I call this a 3, it's going to be a 3 plus 4. And so it's too random, it doesn't make sense to give a Gleason score on something so small, yet pathologists do it all the time. All the time. Here's another series from Johns Hopkins that looked at this issue, and don't read this, I'll just tell you what they found, was that the reproducibility from pathologist to pathologist for giving a percent pattern 4 is not great. It's okay, it's not great, but it's really bad when you have a really small area of tumor. And they actually recommended there that if you have less than 10% of cancer in the core, you shouldn't give a percent pattern 4. And if you say you shouldn't give a percent pattern 4, what you're really saying is you shouldn't even say if it's 3 plus 4 or 4 plus 3. If the focus is that small. They didn't say that though. But that's been my approach. I try to get away with calling something Gleason 7 C common and say I can't tell if this is 3 plus 4, 4 plus 3 because the focus is too small. And deciding which it is just a random exercise. So the accuracy of percent pattern 4 is at best plus minus 10% with a 20% bracket. And with small cancer areas, percent 4 assignment is unreliable and should be avoided. Prostate cancer grading is prone to high variation between pathologists. You want to seek a specialized, experienced, committed pathologist. Be wary of commercial or mill or urologist-owned labs. I'll talk about this in a little bit. Let me give you a couple examples. These are cases that I saw as a second opinion. Someone who got a biopsy diagnosis somewhere else came to our center for treatment, and the urologist had us review the slides. Any great surgeon will want a pathologist he knows to have seen a case because they've all been burned by a bad pathologic diagnosis. Anytime you are relying on someone's impression on a paper report, you cannot trust it if you don't know who that is. If you have, in lung cancer it's different. You can see the surgeon can see the x-ray, they can see the spiculated mass, they know it's cancer, the pathologist confirms it. Prostate, very different. You don't see anything. You're relying completely on what a pathologist interpreted one day. Here's one that came from one of the big commercial labs. This is I won't quiz you guys anymore because I think I've burned you out on that, but this is a pure Gleason 3 patterns. This is a Gleason 3 plus 3 equals 6, and the diagnosis that came to us on this report was 4 plus 3. I don't know where they got all that for, but there wasn't any. Here's one that came from a urology lab, one of those urologist-owned laboratories, and this is all cancer. All this stuff is cancer. The big ones are benign, but all this stuff infiltrating through, this is all cancer. I'll just tell you, this is 4 plus 5. Okay, this is very high-grade cancer. The diagnosis that came to us was 3 plus 3. This came to us as a 3 plus 3 equals 6. This is so obviously a complete error on the pathologist's part. This cannot be explained by pathologist's subjective interpretive differences. And so, of course, when we alerted the pathologist at this referring laboratory of our diagnosis, he looked at the case again and realized that he just had a brain cramp and forgot about this biopsy because all the other biopsies in this patient were pure Gleason 6. So he just diagnosed this as 6 as well. He forgot about this one, I guess, when he issued his report. So he changed his diagnosis. Here's one, no one's perfect. This patient was a friend of mine, so I spent the same level of effort on every biopsy, but it was of particular interest to me. And in this biopsy, I don't have the slide, so I am not photographing the slide, but I sort of drew a schematic of what there was. There was Gleason 3 here, and the biopsy wasn't well fixed, and so there was a problem over here, but there was a big area of Gleason 3, and there was some 4 over here. Okay, so if you just look at this, you would call it 4 plus 3, but if you look at everything, you would call it 3 plus 4. And so this went to the nation's #1 mecca for prostate cancer. I guess I won't say where it was, but it should be obvious to you. So this was my case that I diagnosed as 3 plus 4. It went to the Mecca on the East Coast, and they diagnosed it as 4 plus 3. So I remembered the case very well, and I knew what had happened. They didn't see this. And because this area was not well fixed, and I figured that's what happened. So I called up the attending at this place, and he said, I told him what I thought happened, and he said, listen, we see 80 cases a day, so of course I don't remember what case this is. I'll look at the case again, but I'll tell you now, I'm not going to change my diagnosis. And so I had this epiphany that day, because I had used this place as sort of a reference center to gauge how I was doing as well, to make sure I was sort of in line with the world's experts. And then I realized what was going on there. They have 4 prostate fellows, or GU fellows. They get 80 cases a day, times 10 slides, say 800 slides a day. And the one attending staff sits there and diagnoses 800 slides very quickly on a big multi-headed scope with lots of pathologists. And the fellow who's in training hands the case to them, feeds them the case, and they have to fly through it very fast. And so number one, they're looking at cases too quickly. Number two, there's no place for arrogance in my field. I learned that from my mentor. No matter how good I think I am, I always listen to my colleagues. And if we have a disagreement, I always try to understand the basis for the disagreement. I never dismiss, even though I'm usually right, I never dismiss someone else's opinion. I always consider it carefully. And that level of arrogance that I encountered that day was a real turnoff to me, because I think that gets in the way of good practice. But not to mention looking at, hundreds and hundreds of slides. One pathologist will get hundreds and hundreds of slides a day. They can't put the kind of effort into a case that we do. Sorry,
Did
if you
they,
see this. Pardon?
did they change the diagnosis?
No, they didn't change the diagnosis, but because of the discrepancy, we were asked to send the case to City of Hope, which actually is not really an expert center for this, and they issued the same grade as I did. So they agreed with me. I have no doubt of what happened, and I don't know why they didn't change it, but I learned a lesson, and we don't use them anymore voluntarily. Some people still ask us to send cases there. And that's not to say that I don't think the world of at least their one most famous expert, but the process that they employ is just not something that I really support. I'll skip this one. There's something called intraductal carcinoma. I don't want to get we're getting late, so I'm going to just kind of fly through this. This is one where this came to us graded, but this has a particular look. I won't bother you with the details, but this has an obvious look of a cancer that has been treated. And when you have a treated cancer, that can change the look of the grade, and so we don't grade treated cancers. So they issued a grade on this, and they shouldn't have. This is a treated cancer. They look like Gleason patterns 4 or 5, but this could be a Gleason 3 that was where the glands were shrunk down by treatment. Here is one that in our department, someone in our department called this cancer, and I looked at the case to present at a conference and thought, no, actually this isn't cancer, this looks like a radiated gland, this looks like radiated benign prostate, and so we stained it with a stain that highlights benign gland, and so we had to change our diagnosis. So just to sort of wrap this up, do you need a second opinion? And the key is to start off with a good first opinion. Because the first pathologist, if they're competent, they're going to spend a lot of time, they're dedicated to this and current upon the most current thinking in prostate cancer, they're going to spend the most time and put the most effort into your case. Any second opinion just puts a little less into it because they tend to go faster. So get a good first opinion. Do your findings bring up any problem areas prone to pathologist inter-observer inconsistency, like percent Gleason 4 near a cutoff, or a very small cancer, previous treatment, those kinds of things. Look for clues in the path report that could be a problem, like no grade group assignment. We use grade groups now, we use both. So if someone issues a Gleason score without a grade group, that should be a little red flag. Like this report I showed you at the beginning, a Gleason 3+4 was 7 with no percent 4 assignment or explanatory comment, that's a red flag. Know the kind of lab you're using. Is it a commercial lab? I'll just say it. Is it LabCorp, Quest, one of those labs? Again, that's a lab that I would have never, I graduated high in my class in medical school, I went to Stanford, and I wanted a real job. I would have never gone to work for LabCorp or Quest. They're just sweatshops. In fact, I looked into it recently for one of my colleagues, and they actually make more money than I do. The pathologists, I run my department, and the sweat, you know, the hard-working pathologist employed at LabCorp makes more money than I do. But he also has to sign out, I think it was like 10 times as many cases as I do. I mean, he can't put in the kind of effort that we have the time to put into a case. It's just not good for you. So commercial labs, beware. A urologist-owned lab, same thing. It's a last choice career. It's a last career choice for a pathologist. Prostate specialty mill labs, labs that just do prostate cancer in another state. They're very good at marketing. I have one of my colleagues has a friend who works in one of the biggest prostate cancer laboratory. She looks at 600 slides a day. That's just insane. It's crazy. So I find all those red flags. A legitimate health center laboratory is a hospital that has a pathology department and a group of pathologists that are dedicated to, you know, to this. Academic centers, you know, those kinds of things. Those are places that you want your biopsy to go to. Don't let, if your urologist has his own laboratory, you know, it's probably stressful for you to say, I don't want you to use your laboratory, because your urologist makes money on the biopsy, not only on biopsying you, but then makes money on the pathology part. That's why they have their own laboratory. It's not an optimal situation though. So if you don't want to make trouble with your urologist, then you just keep, you know, a mental note, okay, if there's anything in this biopsy report that I don't like, I'm just gonna get a second opinion, and maybe you eat the cost of a second opinion. Very important to know how your management options hinge on your biopsy findings. If you're considering radically different pathways in managing your cancer based on something on a path report, remember, it's just a piece of paper with someone's interpretation, and I mean, people have bad days. So if you're gonna make a big decision on something that's written on a piece of paper, maybe you wanna consider getting a second opinion. But I think the best thing to do is to make sure you get a good first opinion in the first place. I think that's it. That's it.
Thank you, doctor.
Okay.
Okay, questions back there?
So when your doctor gets
I can hear you. I can hear you.
when your doctor gets a copy of the report, are any of those slides or photos included with the results that you've read, or is it just the numbers? And if it is just the numbers, how do you get a second opinion? How do you get that photograph that you?
I get it. Okay. First of all, photographs are in path reports for marketing. They're gimmicks. Okay. We do it sometimes because some people just want them. Okay. I can photograph one area versus another area, and I can photograph a Gleason 6 and make it look like a Gleason 7. You can't trust a photograph in a report. They're useless, okay? Even if you see a perfect Gleason pattern 6 or 3 on a photograph, it doesn't tell you anything about what the pathologist didn't photograph. So you cannot take any weight you can't give any weight to a photograph in a path report. So the photographs are meaningless. It's just a piece of paper. When you get a second opinion, the slides, all your glass slides, and the report goes to the other pathologist. That's the only way to do this. The photographs in the report are meaningless.
So literally those samples in those slides are going to
the slides are going to another lab, right? And actually in that case that I showed you, with the very first slide that I showed you that was sent to me as a 3+4, that I call the 3+3, I noticed that they sent me one set of recut slides. And that means that there were other slides prepared that they didn't send me. And so I put a comment in my report. I said, it's 6 in this slide, but please send me the rest of it so I can make sure that they didn't have something that I didn't have. Because we have had that problem before. In fact, we've had it in my department where one of my colleagues had a case. It's always better to learn from someone else's mistake from yours. I've learned from my mistakes too, but he was disagreeing on a prostate cancer grade, and he showed it to me for my opinion, and I agreed with him, but I noticed that it was a recut slide. I said, just make sure you get the original slides before you issue this report, because this one, like, there's something fishy about this one. And he didn't do it, and issued the report, and we were wrong. The original diagnosis was correct, and the reason was that we didn't have the key slides. So, you know, that's something that we learned a long time ago. But anyway.
Question on if you have a biopsy and it takes slides and they get read, and then you have a route prostatectomy and there takes some more slides and read. Whatever happens to those slides, how long are they kept? Where are they kept?
They'll keep the slides. I think there's a regulation. You have to keep the slides for 10 years. Most labs keep them for much longer. We keep them for 25, longer if we can, 30. So
And they're still good,
they're still good. Yes.
Next.
Yes.
Any numbers on how many samples a pathology lab like a university may be going through, as opposed to what you were saying for the other types of facilities?
I don't know numbers, you know, that should they differ everywhere. I probably look at, you know, 1 or 2 patients' prostate biopsies a day, as opposed to 80, you know, or 50 or 40 at some of these other labs. I'm doing other things, but that's, you know, yeah, there's no way to know how busy, you know, people can be too busy doing other things. You know, they could look at only 3 prostate biopsies, but have too much of other stuff, and so they can't give enough time to anything. That's what happens at the commercial labs like LabCorp or Quest, because the pathologist is just stuck there. They have to read 170 cases in a day, where I'm reading maybe 30 cases, you know, 20 or 30 cases in a day, and they got to get them out. They got to get them out, and they might not be looking at all prostates, but they just are too busy.
So let me ask you a question here, Doctor. Could you speak briefly on how the Gleason score factors in to selecting with your doctor a therapy to address your cancer?
Well, yeah, I mean, you've had Mark Scholes here, right?
Yeah.
He's spoken here. You know, he's an oncologist that specializes in prostate cancer. He'd probably be best to answer that kind of question. But yes, I mean, if you have Gleason 6, you have the option. I mean, even if you have a lot of it, you still will have the option of just surveilling your cancer and not doing anything. If you have grade group 4, you know, actually if you have if you have an intermediate risk, Gleason 7, like a real 3+4 and a lot of it, or 4+3 or 4+4, now you're talking, you've got to treat unless you have so much 4+4 or 4+5. There's actually, I didn't show in those series, but the treatment benefit is diminished in very high risk cancers because there's such a high chance that the cancer has already spread beyond the surgical area. So yeah, the grade is extremely important because you have a low grade range where you can do nothing, a little bit higher grade where you may want to do active surveillance or treatment if you have a long life expectancy, another intermediate risk grade risk where you'd want to treat because you have a high chance of saving your life by getting treatment, and then a much higher grade or a lot of high volume of high grade cancer where, you know, like a really shrewd doctor will tell you not to get surgery because it's too late, and then they'll manage you a different way and save you the anguish of an operation.
Go ahead.
We as lay people, when we want a, second opinion or first opinion, we go by we hear reputations, like, it might be like Johns Hopkins, I hear it's very good, or other ones are also good, but is it and you know, like, you know, if people, you know, and you showed a study where they, what do you call it again? They, you know, they surveyed the different people, they had different results from the people. And, you know, Consumer Reports does this with cars and toasters. So is there some sort of a consumer report that the layperson could see instead of going by reputation?
No, I don't think there is.
I mean, is that something that's against the medical guidelines that you, because I'm sure there's a lot of bums out there that are giving, you know, as you mentioned. So how do, you know, what do we do? You know,
You've got to, you have to, I think the most important thing is you have to have a urologist or whoever your primary doctor is that you can talk to about this.
yeah, but a lot of people go to the urologist, you know, or wherever they're going, and, you know, they just, you know, whatever the doctor tells them, they say yes, you know, whatever, you know, they don't know what's going on. But wouldn't it be good to have some sort, I mean, I know I want to send my slides to the best. Because my health, you know, I don't want to die from this. I don't want somebody to give me a bad thing. You know, so, you know, why can't we, is it possible to have this quantified, you know, listing, you know, these people who were doing the biopsies?
That's just not, it's just not out there. So,
Is
and
it,
you're right.
is it against the medical?
No, it's just not out there.
Give me a stab.
And the rating,
Stephen Strum.
Yeah, I read the book with he listed 8 of them.
He listed
Yeah.
recommended places
I
where
know,
you go
but
get.
that's his opinion, and that was 10 years
Well,
ago.
you asked where you go.
I know. In fact, I read that, but I'm saying, like, it was just a recent study that you mentioned where they're, you know, they're surveying these people, and you know, and I speak to different people who go for second opinions. You know, they go to Johns Hopkins or you know, some other place, and you know, it's changed. Or
Well,
maybe your institution, you know, which is pretty.
well, yeah, it's a problem because you would have no way of knowing about me. I happen to be, you know, interested in this my entire career. I have put a lot.
I know the hospital you work for is a major hospital. So
You know, one thing you said about the urologist just tells you where it goes and doesn't know. The urologist actually does know stuff. And if you, I mean, I hate to say this, but if you ask your urologist, like, who's the pathologist that you use, and they just give you a hard time or are dismissive about it, you may have the wrong urologist because it's just not cool. You know, I mean, the urologist I work with would give you a very serious answer to that question, and you could even call me. You know, can I call a pathologist? You can call a pathologist and ask him, you know, what's your interest and experience in looking at prostates? How much time do you give them? And you know, but your urologist should be able to tell you, no, this guy is really good, or your urologist dismisses you or blows you off, and then you have something legitimate to be concerned with.
No, I understand what, you know, we do this, you know, as people, you know, we understand this, but I'm just saying it would be nice to have a consumer report for.
I know, but those things are usually unreliable. I've seen them, you know, like in magazines, looking at best doctors, and I know a lot of the doctors, and I'm thinking, this guy must have paid money for this because he's not even close to the best.
The super doctors and all that.
Yeah, those things are just bogus. I got a phone call from, I'll get to you in a sec. I got a phone call from America's Top Doctors, and they wanted to, you know, they had awarded me something, and I called them back, and I was going to accept it if there was no money involved. If I had to pay for it, I'm just thinking, I don't even want to be a part of something like that. And they gave me the whole cell, and in the end, I did have to pay to get like this or that. And I thought, I don't want to be rated in something like that. So I said, no thanks. I don't know, it's tough, but you can ask questions, and based on the kinds of answers you get, for example, I work with a urologist, I'm just going to name his name, Tim Wilson, at St. John's. He came from City of Hope. If you asked him about your pathologist, who his pathologist is, who looks at biopsies, he'll give you a very eloquent, serious answer, and I think you would have a much better feeling about where your biopsy is going. If you ask another urologist, I mean, you know, you can learn a lot by asking questions, and having your questions dismissed is a bad sign.
Any other questions?
Yes.
Thank you for your presentation. Does your, where you work, where you head up, do you accept slides from other pathologists or other
Yeah, we do.
institutions?
We do second opinions all the time. I'm not here to solicit second
I
opinions,
understand that, but I just
you know,
wanted to.
but I mean, we do them, and, you know, patients have sent stuff to us. They've heard of me or someone, you know, for word of mouth. I'm not famous like, you know, Dr. Epstein. You know, I'm not going to get anything like, you know, I don't have a consultation service for me, but we look at cases in second opinion for our urologists all the time, and I have looked at, sometimes a patient has sent me a case, and we do that. I'm not here to sell that today, but yeah, we do that.
Great, thank you.
You worked with Dr. Stanley, didn't you? I mean, along, right?
Well, that was 30 years ago.
Yeah, but I mean, you did work with him.
Well, yeah, it was really, he's a urologist, and the pathologist there who became somewhat famous later was Dr. McNeil. He did most of the pathology, and we looked, but, you know, things have changed so much since then. But, yeah, I think I have a good handle on
Any
this.
other questions?
I was going to make a comment on your consumer report. My experience in the field that I came from, I know for a fact the consumer report, there is some manipulations that go on within these recommendations that are made. Another good example is J.D. Power. Are you familiar with that?
Yeah.
And that they've really grown because they started off basically in the automotive industry, rating things, and now they're into everything. And you can't help but feel there's a payola in there somewhere.
Yeah, I think you have to just be able to talk to urologists. You can even call your pathologist. You know, you can learn a lot from talking to somebody. Someone is really eloquent with you, and they know what they're talking about, and they're not dismissive, versus you kind of being blown off. I mean, and that is very common. So you can learn a lot just from asking questions.
Charles, do you have a question?
Yeah, the slides, who owns the legally owner of those slides?
Why does it matter?
Pardon?
Why does it matter? Why are you asking?
Oh, why am I asking? I had a biopsy about 11 years ago, and I went to get my slides, and they wouldn't give them to me. This was at Hogue.
At Hogue? Did you tell them why you wanted them?
I wanted to go get a second opinion. They said, well, we have to send them to the other place.
All right, well, that's an odd, you know, I know those people, and I'm surprised to hear that.
And I raised a little hell, and they finally gave them to me.
Yeah, so there's actually, the law is not it's not perfectly clear on that, who owns it, and this has been a point of controversy. So actually, no one is certain, but the bottom line is the hospital is custodian on your behalf of those slides and should do with them whatever is best in your best interest. And when you ask for them for a legitimate purpose, they should be willing to give them to you. If I'm worried that you may be hurting yourself by, you know, taking the slides, you're going to lose them, you know, I don't know if that's what Hogue is thinking, but we're supposed to be, you know, we're on your side, so it shouldn't matter who owns the slides, and actually law has been vague on that.
They required me to sign a statement that I would return them. So I took them to USC, and I made them sign that they would give them back to me.
Yeah.
So they gave them back to me, and I still have them. And I don't have cancer.
Good,
And
good.
they were pushing me to have a surgery at Hope.
Oh boy.
Maybe HIPAA laws might preclude them from being given out to anybody else.
No, you can. No, I mean, with patient's permission, we send slides anywhere if the patient wants us to, even if we think it's a bad idea.
When you're sending them, say, to you or if you're not available, Johns Hopkins, you know, do they have to pack the slides in a certain way to send it out? Is that better than you would do it yourself, maybe?
I think so, because we do it every day.
And
Yeah.
I guess there's a charge for it sometimes not.
I don't know if our lab charges for it actually for sending them out, but it's not a big it's
I
not
think
much of
better
one.
that, I think it's better that the hospital,
Oh yeah, if you're gonna have it sent to Hopkins, you should have the hospital do it. They track it better, they're responsible for it. It's just better to do it that way. Your chances of screwing up are higher than the hospital's chance of doing that.
One more question.
Okay,
Thank you, Doctor.
Thank you.